those medications failed you. You didn't fail the medications. Let's move on to something new. We can give this a shot.
Hello and welcome to the Scale Up Your Practice podcast brought to you by Obesity Canada. I'm Dr. Roshan Abraham, family physician and associate professor at the University of Alberta. For obesity, historically, people have been told to just eat less and move more, with few therapeutic options that address the comprehensive approach needed for this disease. Between 2021 and 2026, though, the science of pharmacotherapy has shattered that paradigm, addressing the underlying biology of weight regulation. We're no longer just looking at modest weight loss. We're looking at medications like triple agonists and oral molecules that normalize neurobiology and fundamentally alter the trajectory of this chronic disease. It is time for our clinical practices to catch up to science. So today, we are diving into the current obesity pharmacotherapy landscape. Specifically, we want to help you master the skills needed to confidently collaborate with your patients to assess and prescribe these rapidly evolving medications. To help us navigate this, we are joined by a globally recognized researcher, internal medicine specialist, and the co-lead of the 2020 Canadian Adult Obesity Clinical Practice Guidelines lead author, Dr. Sean Wharton. Dr. Wharton, welcome back to the show.
Thank you very much. I'm really excited to be here because, we're going to talk a little bit about all the new emerging research. I'm literally in my clinical trials division right now. So I'm not in the clinic. I'm in the clinical trials area where we work on clinical trials every single day. I'm seeing patients getting new medications, new therapies, new advances. So we can dig right into that.
This is truly an exciting time for the field and for medicine overall, and I am grateful that you've taken the time today to be our guest once again, this time in season 2. So Dr. Wharton, the pharmacotherapy landscape has dramatically changed over the last few years. Emerging therapies are moving from single pathway GLP-1s to non-peptide oral pills and triple agonists. For the busy clinician listening, what do these therapies change about how we can support more comprehensive care for patients living with obesity?
I love that question because it digs right into immediately what is the unmet need? Where exactly are we? So where we are is that there are essentially 4 medications in Canada right now that are working relatively well. They're doing pretty good, particularly if we look at semaglutide 2.4 milligrams, which is approved in Canada, and tirzepatide 5, 10, and 15 milligrams. So those 2 molecules give you anywhere from 15 to 22% weight change. Pretty darn good. Now, and the unfortunate thing is that some people just don't do well on it. So we have this thing called a waterfall plot where we rank every person's weight loss. And on an average, then, if you're looking at the tirzepatide molecule, on average, you're going to get an average of about 21%. That 21% is made up of people at 5% weight loss and someone at 30% weight loss and a couple of people with weight gain. So who are these people? What are they doing gaining weight? Are they injecting it? Are they injecting it into the air? If they're really injecting it, how could they possibly gain weight? But there's that group. 1, there's a group that's gaining weight. 2, there's a small group that didn't get significant enough weight change on the highest dose. So those people are missing out. They're missing out on their visceral adiposity, decreasing their comorbidities, getting better. How can we help them? Well, we're not going to help them with just a higher dose of the medication because it's just not working for them. What frequently works is a new medication, a different twist, hitting a different hormone, a different receptor. And that's what some of these newer molecules are going to do. They're going to get to that problem area that we don't quite understand. We don't understand why it's problematic, but we understand we may be able to get to it with different molecules with a little bit different target.
And I think that mentality of going in, just as a primary care physician, that's actually how I've been describing some of the, the evolution of treatment to my patients, because a lot of them are actually getting frustrated, right? Because they feel that they've sort of maxed out these doses. We've been doing it from a multidisciplinary standpoint and sort of being able to tell them about how the body, and we might not quite know it yet, biologically defends that weight, right? And that metabolic adaptation, and how we need to start looking at different approaches and to not necessarily add on to that internalized weight bias and stigma because they feel like this is one other thing that they've actually missed out on.
Right. Exactly. That's 100% right. And that's why in some cases, what we didn't do is we didn't maximize the dose in the research. So for instance, in semaglutide 2.4, when we did that big trial in 2020, now what we've discovered is that maybe 2.4 wasn't the highest dose. Mm-hmm. Maybe we could go higher. So what they've done is triple the dose to 7.2 milligrams. So a nice trial in the Lancet. I was lead author of that. At triple the dose from 2.4 to 7.2 milligrams gave us 3% more weight loss. It's not a lot more weight loss, and it probably is not going to impact the people who had no impact from this medication. They're not doing well with the molecule. They need a new molecule. But for those who wanted to go up a little further and were doing okay, they could crank up to 7.2 milligrams. So that's going up in dose. Next, let's switch the molecule totally. And I believe that we'll see the people who didn't respond possibly respond to these newer targets.
Again, Dr. Wharton, you've been a strong advocate for changing how we communicate the mechanisms of these medications to patients, which I find incredibly valuable to as a generalist and as a medical educator. You often talk also about the neurobiology of food noise. How do you explain food noise in clinic, and what do you notice shifts for patients when they realize this is about regulating biology and not necessarily about willpower?
Food noise has been a new term over the past 5 years or so, but we've always had it. We just called it something different. We called it hunger, cravings, intensity, and getting hangry. So hangry is food noise if that hunger and angriness lasts for a long time or dictates your day. And that is what we're talking about. We're not talking about simple hunger. We're talking about addictive type of behaviors, even when you try to stop it. And nobody wants to live with that food noise because it stops their functioning with their partners, with their relationships, and they're trying to listen to somebody, yet they're thinking about food, or they're thinking about getting away from them. How quickly can I get out of this conversation so I can go eat on my own? How can I get home by myself so that no one else is there so I can eat before anybody else makes it home? How can I hide food? Wrappers and things like that. How can I hide my drive-through to throw away stuff before they get home, so it's not even in the car? And this isn't binge eating, which is another disorder, comes close to this, but it's not the same. And so if you can get rid of the food noise, you are a new person, because everybody living with obesity wants to eat healthy, wants to eat healthier, wants to eat smaller portion, wants to eat regular. They're not doing this out of a sense of lack of character. And once you give them that ability to eat healthy, oh man, they're the best. They're the best healthy eater, and they're structured and organized and coordinated. And it's a joy to actually see. So if medications can help to quiet that, the same way medications can help to quiet schizophrenia. A person with schizophrenia doesn't want to hear the noises and the voices. Quiet it down so they can focus on your conversation and go to school and be structured and be there. So you have more available real estate, we call it, real estate in your brain, to be able to function on a daily basis. That's what these medications often do.
That is so well put. And again, coming from a family physician, primary care standpoint, I have now at least a handful of patients where one of the primary goals or even secondary goals is about reducing that intrusive, obsessive thought about food. And in fact, in some cases, we've actually not needed to increase or even start antidepressants as a result of that, because we're actually stopping this noise. And it wasn't until we actually started it that they realized, oh, I don't actually need to start an antidepressant because these intrusive, obsessive thoughts about food aren't there. And really about having that holistic approach, because everyone's different in terms of how these obsessive thoughts come about with food, and then the self-blame that's been there since you were a child, whether you're living in the same place that you were before or not, the locations that sort of bring about that food noise that maybe are attached to some childhood memories as well. Going through that holistic approach really increases long-term adherence to the medications and then also relieves that patient self-blame, which I find is really powerful.
100%. And there's new emerging research showing that people living with depression and mental health disorders actually can have enhancements of their medication. They can feel better on their medications, take lower doses of their medication by treating their obesity first. So treating obesity first may be one of the better ways to do it. But back in the day, I'm talking 10 years ago, in my clinic, we set up a system of treating the mental health condition first and saying, you don't need weight management treatment. We're not going to give you weight management because you need to get your mental health in order. And we're now learning that may have been the wrong way to do it.
Exactly.
Get their food noise and their obesity in order, and they can now do their mental health so much better. We're fighting against a brick wall when in fact we could have been having a much easier management of their mental health if we just took control of their weight management and their food noise in their brain a little bit earlier.
And recognizing that that's a little bit of systemic bias and stigma that basically told us as clinicians that we should probably address the mental health issues first before actually addressing the weight side of things. So I think that switch has also been powerful for a couple of those patients, for them to hear from us that this could actually be beneficial for their mental health and not to prioritize that first and sort of think of weight or obesity as sort of a secondary illness or secondary disease. Before we get into the next part of our conversation, if you're listening and thinking that you'd like to feel more confident prescribing obesity medications in your practice, Obesity Canada has a resource for you. Our latest accredited course, Pharmacotherapy and Obesity Management, is online, self-paced, and walks through the latest 2025 pharmacotherapy clinical practice guideline update. Scan the QR code on screen to enroll today or click the link in the show notes. So Dr. Wharton, despite these incredible advancements, there's still a massive amount of stigma around these medications. We see healthcare systems and even some providers framing these as quote unquote the easy way out or just a quote unquote weight loss journey. The new Canadian guidelines and ADA standards heavily emphasize eliminating this bias. How does this systemic bias actively harm patients, and how must we change our language to dismantle it?
And this is a great question. And it's the reason why I think it's such a great question is because I just finished a teaching session where I was part of a teaching session for a different country. During that, there was a lot of discussion around the table, and oh my goodness, was it biased. There was some comments about the fact that I will not let my patients be on these medications unless they tell me what they're going to do for their exercise, what they're going to eat, and they stick to it, and etc. It blew my mind because there are cardiologists in the room, and the cardiologist wouldn't say, if you don't eat the Mediterranean diet, I'm not putting you on this cardiac medication. If you don't go to the gym on a regular basis, if I don't see your gym membership, you're not getting this beta blockade inhibitor aspirin. I am sorry. You're not getting my medication, not from me. That was the discussion. You're not getting the weight management medication from me if you're not shamed and blamed into ensuring that you check in with me every week to show me that you went to the gym or show me your food diary. I had to breathe and relax because those biased, stigmatizing viewpoints, which some of our friends share, some of our family members share, my parents, it's not going to be easy to change this. We are a small number. So when we talk about bias, stigma, and discrimination, we can't preach it loud enough. We need to keep on preaching it. We need to give people actual examples of what we're talking about, because they can't see it in themselves. They're like, racism back in the 1930s and 40s. They're like, we believe that, Black people should, they're just not bright. They can stay with themselves. We're not against them. They need to stay in their own spot with their own people. They're happy. They're not bright. They're not really capable. So they're happy by themselves. That's why there's all these jolly pictures of Black people, hanging out in the South because they're not bright enough or capable enough to move forward. That's very clear now that that's racism. But it wasn't clear to the person in the 1930s. They were the kindest, nicest person ever. This is the same kindest, nicest person ever yelling at their patient to exercise better. And what didn't you hear that I told you last week? Nicest, greatest doctor. They think they're terrific.
You've spoken beautifully about the love pillar in obesity management. The idea that being heard and cared for is just as essential as the prescription pad.
Right.
Stemming from what you've just said, so when a patient sits in front of you and they're either able to feel the relief of their biology being regulated for the first time, or you're able to explain that with a lot of these emerging therapies or our current therapies, that they can actually feel that relief. How is it so important for us to link that, again, the pharmacotherapy, that prescription pad, to also the piece that we love and care for our patients? And how can some of these emerging therapies actually help with that?
Patients sometimes coming in with a medical condition or problem want to be either hugged, heard, or helped. So you're not going to physically hug them. The hug is listening to them, understanding and saying, I appreciate how challenging that must have been. And it sounds like just a cliched statement, but it was hard for them. They hear you saying that and they appreciate that empathy, and give them a second, because it was hard, whatever they happen to be talking about. Next, to be heard. Sometimes they just want to spew out a whole bunch of stuff. And it's like, get it off of their chest. And they didn't necessarily, they're not looking for help. They're not looking for advice. They're not absolutely looking to be hugged. They're just looking for somebody to hear the challenges that they had. They know that you don't have hours, but you can hear a little bit of what they need, and they may not need help, and you can ask them. And that's where the ask comes from. The ask is about the help. We're in a position now where we understand much more about weight management. Would you like some help?
Yes.
In regards to your weight management? We can move from things like, you were on this dual agonist, which was our best thing that we had at the current time. But you still didn't get the impact. Would you like some help to move forward with some of the newer medications? We've got a new trial with an agent that adds an amylin, this new molecule that sensitizes the brain to leptin and the weight management regulatory hormones that are good regulatory hormones. This amylin sensitizes it and makes it stronger. We can give this a shot. Now, I'm not absolutely sure it's going to work, but we can move forward if you would like to move forward on yet another treatment, because that's what I'm here to actually do. Those medications failed you. You didn't fail the medications. Let's move on to something new, even if it's in a clinical trial, because I work in clinical trials. We may be able to do that for you in a clinical trial.
I'm drawing from so much in my own practice about similar words, maybe not the exact same phrases, and how that relates back to the compassionate chronic care relationship and what that actually looks like. I think it's imperative for us, especially as primary care physicians, but all clinicians, honestly, to say this is what the roadmap looks like. There are options, and we're here with you, guiding you, collaborating with you on this. And I think that's such a powerful statement around compassionate chronic care, because it's relationship building, and being able to communicate that in simple terms. And just as you've put it too, is so beautifully put. And I'll be taking that back for me as well, just in terms of how I might communicate some of these emerging therapies if it comes up in our discussions, I think is a really powerful tool for our listeners.
Yes, and sometimes it's not at that doctor's center, that the clinician center. They don't run a clinical trial division, right, but there are clinical trials divisions in their city. They are on the internet. You just start Google. I'm interested in weight management clinical trials. I'm interested in it. I may not absolutely do it, but I'm interested. So, and then you start to walk down the road, and then you start to see whether that's something that works for that person who's looking for the next step. They can always wait until the clinical trials are done and then have the medication, once it is approved. But we do find people that want to help to answer the question of, does this work in this patient population? I'm always amazed at my clinical trial patients. I'm like, what are you doing here? Why are you here? How did this? They're like, I'm actually interested in helping to forward research. I'd like to, I know that this may be able to help me as well. So I'm super interested in that. And I'm super interested in helping the research field. I'm like, this is terrific. And it's not everybody that is out there like that. So don't think that the people who are like that will move forward. They'll be here. And those are the people that you want in the clinical trials. At least you're offering them something.
So Dr. Wharton, one of our last questions today is, what is on the horizon? What are some of the new and emerging therapies that are getting you excited about, again, this chronic disease management and how we can better manage obesity care for our patients and really tap into that compassion with chronic disease management in this condition?
So one of the things that I've always worked on is access to care. And so I believe that the populations that have the highest rates of obesity and type 2 diabetes are the ones who get the least amount of care. So that's the indigenous population here in Canada and African-American women in the southern states. They have the highest amount of obesity, the highest amount of type 2 diabetes, and get the least amount of care, and access. And all the treatments we've talked about previously were injectable treatments, which means cold chain. Cold chain's that fancy terminology for it's got to stay cold in the fridge, but it's got to be shipped cold. So it means that to be in a cold plane, in a cold truck, getting over to the pharmacy, and then eventually getting to it. So think of the highest rate of obesity in the world is in the Polynesian Islands. Are they getting cold chain injectable medications all that easily? And they're also poor. They have a lower socioeconomic status and strata there. They're not getting these injectable agents. So can we flip the switch and give oral agents? Because oral agents may give us a chance to treat those populations that have not been previously treated. This is going to change a lot. Cardiologists don't like giving injectable medications. Not because they can't do injectable medications. They do PCSK9 inhibitors, which is fine. They do injectable medication. They don't want to do this injectable medication because it means a refill of a script, a patient coming back, my partner changed their insurance. Can you switch it for me? They don't want to do that, but they will give a pill that is easy to give, easy to titrate, is part of their pill regimen that they give with their patients. So cardiologists, GI doctors, specialists, family doctors, patients asking for it. So there's two barriers. There's the barrier sometimes with the patient, but the barrier with the patient isn't nearly as big as the barrier with the provider. Providers don't like prescribing things that cause them to have to do refills and challenges. This is going to change that. When you change something that's that critical to the operation chain, it changes everything. So that's why we are excited. It's important to explain it as not just orals coming to the market. No, this is a big change.
I'm excited about increased access, improvement in sort of how we address social accountability and equity. And I'm not even a dual trained pharmacist and internal medicine specialist like you are. I can't imagine what it's like to be in your shoes and being in this world and being in this field. Again, I'm a generalist. I work in a generalist practice. Obviously, I see a lot of obesity as a chronic disease, and it's slowly becoming more of an interest for me, but I still represent that primary care perspective. I can't imagine what it's like for you with your previous training that you get to now bring into the everyday work. I mean, you were doing it before, obviously, but now it's just hearing from what you is making me excited, and I'm not even a pharmacist.
Yeah, and it's really exciting because of that science side of it, the pharmacokinetics, how the kinetics of a drug being absorbed and going into the bloodstream, and then the dynamics. Does it actually get to the receptor and work? So all of these we call geeky things, but the science things and the biological things really get us excited from a science standpoint. But then to see it in operation, to see it for a patient that's not concerned about all the kinetics and the pharmacodynamics, you're just like, does it work and can I get access to it? And can it change my trajectory? Can it change the way I show up to work? Can it change the way I show up with my family? Can it allow me to walk up a flight of stairs without shortness of breath? Can I pick up my grandchild? That's what we're talking about.
Dr. Wharton, I am so glad you came back for another episode, and hopefully we have you back many more times. For our listeners, in summary, we covered the rapidly evolving landscape of obesity pharmacotherapy, some of the current therapies as well as emerging therapies that we are obviously excited about. We discussed how treating the neurobiology of food noise is fundamentally changing the way that we practice medicine. We discussed how mastering this knowledge allows you to dismantle the stigma that calls these life-saving treatments the quote-unquote easy way out. And when we understand the science, we can truly practice compassionate, person-centered care. You can find direct links to the 2025 update of the Canadian Adult Obesity Clinical Practice Guidelines and a link to the Pharmacotherapy for Obesity Management course. Please visit them to dig deeper into the evidence. New episodes of Scale Up Your Practice drop every second Thursday, so make sure you are subscribed so you never miss an episode. If today's conversation was helpful, please take a moment to rate and review us on your favorite podcast platform. It helps other clinicians find the show and bring this learning into their practice. Thank you again, Dr. Wharton, for guiding us through this. It was a pleasure, and I hope that our listeners also got a great opportunity to learn again from you.
Cheers. Thank you very much, Roshan.
Until next time, listeners, stay curious, stay kind, and keep scaling up your practice. This podcast is intended for informational and educational purposes only and does not constitute medical advice. The content shared in this podcast should never be used as a substitute for professional medical advice, diagnosis, or treatment. Always seek the guidance of a qualified healthcare professional with any questions you may have regarding your health or a medical condition. The information and treatments discussed in this podcast are based on Canadian guidelines and approved practices as of the time of recording. If you are listening from outside of Canada, please consult your local healthcare professional to ensure compliance with your region's medical standards, guidelines, and recommendations. The creators of this podcast disclaim all liability for any decisions or actions taken based on the content discussed. Listening to this podcast does not establish a professional or patient-client relationship.